Hello, I'm Sue Popkin, Institute Fellow and co-director of the Urban Institute's Disability Equity Policy Initiative, or DEPI. I am an older white woman with salt and pepper hair. I'm wearing glasses and earrings and a green scarf and a green jacket. I am a disabled researcher. I have Sjogren's disease, autoimmune disease. DEPI is working to build a body of evidence to improve the lives of disabled people. We aim to equip policymakers and practitioners with the rigorous, timely, and actionable research they need to advance economic mobility, housing stability, community connections, and a more accessible and equitable public safety net. We are very excited today to be collaborating with our colleagues from the University of Montana Research and Training Center on Disability in Rural Communities, or RTC Rural, and we're looking forward to an exciting conversation today. I have a few logistics to review before we get started. CART services are providing real-time closed captioning. ASL interpretation is also being provided throughout the entire event. This event is being recorded, and the recording will be shared following the event. Audience members are muted, but please use the Q&A box to ask questions to our panelists at any time. We have reserved time at the end of each panel to ask some of these. I'm very pleased to welcome our 5 panelists who will discuss priorities for ensuring rural disability representation across all levels of data collection. And this conversation takes place in the context of a larger discussion about the limitations of the existing measures of disability in the American Community Survey and about the proposal to replace these questions with the Washington Group short set questions. Many researchers and advocates, including those here at Urban, have called for more research to develop better measures of prevalence. And the Census Bureau has listened to those concerns and has paused those plans for now. You can see some of the research links on our event page. We have an opportunity today to contribute to the national discussion by highlighting the important but often overlooked intersection of rural places and people with disabilities. Our conversation today will be split into 2 discussions. First, we will invite 2 panelists to share their experiences as disability researchers working with rural disability data with a focus on disability measurement and data collection. And second, we will visit with 3 panelists who use data in their work to elevate rural people with disabilities. And for our first panel, I will turn things over to my colleague, Corianne Scally.
Thank you, Sue. Hello, everyone. I'm Corianne Scally. I'm a researcher here at the Urban Institute, where I work on policy relevant and equity-focused research, including work on rural communities and on people with disabilities. I am a white woman with shoulder-length brown hair and an increasing amount of white hair, and I have invisible disabilities. I am very pleased to moderate this first part of our conversation today on strengthening rural disability data with 2 researchers who work in university centers focused on rural and disability research. I will ask them to join us now. Andrew Myers is the project director for the Research and Training Center on Disability in Rural Communities at the University of Montana, our partner on this event. And Kelsey Goddard is the research project coordinator for the Research and Training Center on Independent Living at the University of Kansas. Thank you both for being with us today. You can find out more information about their work by checking out their full bios available online. And as a reminder, please enter your questions for the panelists at any time into the Q&A box, and we will be reserving the last few minutes to try and address as many of those as possible. All right, so to get us started, you've both spent significant time working with and analyzing disability data from a range of data sources. My question is, why is it so hard to get good data on rural communities? And Andrew, let's turn to you first.
Hello, Corianne. Thank you for having me. Yes, my name is Andrew. I'm a white man in my 30s with short hair and some facial hair. Yeah, that's a fantastic question. So I have 3 things I'd like to bring up. One is about definitions, one's about data, and one's about So there are more than a dozen different federal definitions of rural, and depending on what you use, you might get anywhere between 72 to 97% of the total landmass, or 14 to 20% of the total population. And it's important to also note that the concept of rural isn't actually defined in most data sets. So the actual definitions of rural are actually what's called non-metropolitan, which we interpret as rural. There are also typically deficit-based measures. So whether it's lack of population or lack of economic activity, it's usually defined by a lack of something. So in many ways, I like to think of it as rural as like a non-geography. I'm a geographer, so it's like not really defined. It's really the urban leftovers that we work with. It's also important to know that each definition uses different boundaries and different metrics. So some of the boundaries might be like census tracts or counties or urban, what's called urbanized areas. Some of the metrics are things like populations, commuting patterns, or economic activity. And this is important because this means that a place can be urban in one definition and rural in another. So there's a little bit of subjectivity regarding which definition to use, but ultimately is usually determined by whatever data is available. And so there's really no single data set that includes all the information we might want as rural disability researchers. This means we have to link across different data sets, which can be complicated when we're doing data analyses if the data sets don't match well. Um, so another thing to consider is the quality of data. And when I say data here, I'm talking about like quantitative data, numbers. It can be difficult to assess how well does it accurately reflect the reality on the ground, especially for rural disabled folks. The American Community Survey is one of the best data sets we have when we talk about rural disability data. But even there, especially when we get into smaller geographies of very rural places, the margins of error are very large. And it's hard to do intersectional analyses. So when we're talking about like disability and race and gender, if we want to look at all those things, it can be really hard because the sample sizes get so small, even in a nationally representative survey like the ACS. And I know Kelsey's going to talk a little bit more about that. Another thing to consider is rural places themselves. So recruitment and trust are huge issues, not just in the US right now, but especially in rural areas and especially among marginalized populations. And rural areas have a long history of exploitation and disinvestment. There's lots of hospitals that are closing and healthcare centers that are closing due to that disinvestment. It also means that recruiting study participants and collecting data in rural areas and among populations and people that have long been underrepresented is really hard, and it's getting more and more difficult. I also want to point out that rural areas do have unique strengths. For example, informal relationships and shared values among people that folks with disabilities rely on daily to meet their needs. These are things like social capital and human capital. These are unique rural resources that are just not captured in national data sets. So with that, I'm gonna cut my time and move on to pass it on to Corianne or Kelsey.
Yeah, thanks, Andrew. It's great to be here today. I'm Kelsey Goddard. I'm a white woman in my 30s, and I use a wheelchair. And I live in a rural area, right outside of St. Joseph, Missouri, where poverty and disability are deeply interconnected. St. Joseph has a long history rooted in both agriculture and industry, and many people in my community work physically demanding jobs in these sectors. Unfortunately, the strain from these jobs frequently leads to long-term disabilities, both physical and mental, which I continue to witness firsthand. The lack of adequate compensation, lack of health care, and lack of paid leave in these industries only makes things worse, causing stress, anxiety, and depression to rise alongside physical injuries. This cycle of poverty and disability is made worse by the fact that we often lack the data needed to fully understand the challenges facing rural communities. While national surveys are crucial tools for gathering information on health and disability, they frequently overlook important rural specific indicators. For example, questions on healthcare access need to specifically address the distance and time it takes for rural residents to travel to medical providers. Surveys should assess the availability of transportation, asking whether rural residents rely on personal vehicles or community networks. Data on social support systems should include how often residents rely on informal caregiving networks like family or friends due to the absence of formal caregiving services. And surveys should also assess broadband access for telehealth or telework, asking if residents have reliable internet and whether poor quality or lack of access affects their access to care or employment. However, it's important to recognize that not all rural communities are the same. As Andrew was talking about, rural areas can differ greatly in terms of economic base, infrastructure, and social networks. So, for example, some rural areas may be built around farming or ranching, while others are industrial or more tourism driven. These variations mean that the challenges faced by people in one rural community may be completely different from those in another. Yet, current data collection methods often fail to capture these important distinctions. By treating rural areas as a single uniform category, we miss the nuances that make each community unique, further limiting our ability to create policies that effectively address their needs. On top of that, even when efforts are made to collect rural specific data, they often fail to reach the most remote and marginalized populations. People with disabilities in rural areas are particularly hard to reach because surveys often rely on standard contact methods like phone or internet, which may not be readily available or accessible to them. Many rural residents with disabilities face challenges like unreliable internet access, lack of cell phone service, or physical barriers that make it difficult to travel to locations where surveys are conducted. Additionally, people with disabilities may require alternate formats or assistance to participate in surveys, but these accommodations are rarely built into standard survey protocols. As a result, people who are already struggling with access to healthcare, transportation, and services in rural areas are often left out of surveys altogether. Their experiences, which could inform much needed policy changes, remain invisible to researchers and policymakers alike. The exclusion of rural populations from national surveys results in significant gaps in our understanding of the challenges they face. But even when these data are collected, there's often a lack of contextual understanding and how it's interpreted. Many researchers and policymakers are based in urban centers and may not fully grasp the unique realities of rural life. This urban centric perspective can lead to misinterpretations of the data or policies that don't address the specific needs of rural communities. So, in the disability community, we say a lot of time, nothing about us without us. But as rural disability researchers, we might add, if you don't know our land, you can't understand. And that's why how we measure disability is so important, because without capturing these diverse experiences accurately, the real challenges people face in rural areas remain invisible.
Thank you so much. And, at a place called the Urban Institute, we try and take a position of humility and partnership and really appreciate the opportunity to partner with researchers such as yourselves and ensure that we're doing our job in applying a rural lens to our work as it's definitely needed. Thank you both for your answers. I think you really captured the growing recognition that current methods of measuring disability, particularly in rural places, are inadequate and are often leading, unfortunately, to a further lack of inclusion and representation in the data that is being collected. Fortunately, there is an exciting and important national dialogue happening right now around disability measurement. Kelsey, we'll go back to you again first. As a person with lived experience in both the rural and the disability space and a researcher, how do these conversations that are happening today matter for rural communities? And can you share some, concrete examples from us from your work and the research you do?
Yeah, absolutely. So I think when we're talking about why disability measurement matters so much for rural communities, we can explore this by considering two key reasons. So the first is that we need to recognize that rural areas often have higher prevalence of certain types of disabilities, such as substance use disorders or mental health conditions. So, for example, rural communities frequently face higher rates of opiate addiction, alcoholism, depression, and anxiety. These conditions are disabilities, but they're not always captured by widely used measures like the ACS6 or the WGSS. So these tools focus really heavily on functional limitations, such as asking questions about difficulty walking, difficulty seeing, difficulty hearing, but they don't really necessarily identify disabilities related to mental health or substance use. So, for instance, someone with PTSD, depression, or addiction may not have functional limitations captured by these widely used measures of disability, but still experience profound disability. And so, because these measures do not adequately address conditions that are common in rural areas, entire segments of the rural disability population remains invisible in our data. And second, when disability data does not accurately reflect the prevalence or diversity of disability in rural communities, our policies and programs will inevitably fail to address the specific needs of those communities. Without accurate data showing the extent of substance use disorders or high mental health conditions, for instance, we might miss opportunities to invest in the right services, like mobile mental health units, like telehealth programs, or community based addiction recovery services. So instead, we end up with policies that are more suited to urban centers or that address only a narrow slice of the disability experience, leaving rural communities under resourced and underserved. And so this is where the work that we've been doing with the National Survey on Health and Disability, or what I'll refer to as the NSHD, comes into play. So the NSHD is conducted by researchers at the University of Kansas and myself, and provides an opportunity to address some of these limitations in our current measurement tools. So our approach has been to explore new strategies for disability measurement that are more inclusive and representative of experiences, including those of rural residents. And we've implemented a few key strategies that I want to highlight today. Um, First, we've incorporated what we call a broad net question. So instead of just asking about specific functional limitations, we ask a broad question such as, do you have any type of health condition, mental health condition, or disability that's lasted or expected to last 6 months or more? And so that question really helps capture people with disabilities who may be missed by more narrow measures. And then, second, we allow respondents to self categorize their disability from a list of broad categories. That method offers people the opportunity to choose the category that best aligns with their lived experience, whether it's a mobility disability, a mental health condition, chronic illness, sensory impairments, or another category. So that approach recognizes that disability is diverse and multifaceted, and it ensures that people have control over how their disability is represented in their data. And then third, we allow respondents to provide open-ended descriptions of their disability to really empower them to describe their disability in their own words. So our research and the work of others here today, like Andrew and Sue, has really demonstrated that these more inclusive approaches to measurement provide a fuller picture of disability. When we get disability measurement right, we can better understand who is disabled, where they are, and what they need.
Thank you so much. Great food for thought. And a reminder to folks to please drop questions into the Q&A box. We'll be turning to your questions shortly. Andrew, I would like to turn to you. With new opportunities, often come new challenges. What are some potential challenges that we will need to navigate along with these opportunities that are part of the national discussion today?
Thank you for the question. Yeah. So we know that as Kelsey demonstrated and discussed, disability is kind of hard to measure, you know, in national surveys, and so is rural. It's got a lot of nuances there, but it is absolutely critical that our conversations about disability measurement to include rural perspectives in that. And we need to be able to communicate why we need improved measures of disability and how that's connected to rural definitions. And as Kelsey mentioned, that's part of that is because disability is more prevalent in rural areas. And one way to try to address that is that, we could include rural urban indicators and data while still omitting the specific locations. So there's one way of kind of providing enough privacy in some of these smaller locations while still providing enough data to do rural urban analyses. It's also important to know that the disability measures we're working with right now are not great. They're fairly old. And so there is a growing discussion that we need a better measures of disability. And there's been efforts to improve those measures, but we also need to be intentional that we don't throw the baby out with the bathwater. We need to make sure we have overlapping time periods across data sets to ensure continuity of data. And that's a bunch of academic jargon to basically say that we need 5 years of data collected in rural areas um, to ensure that we provide accurate estimates. So when we work with rural data from the American Community Survey, you need 5 years of data collected across time to get one observation because the populations are so small. So if we change a definition or something in the ACS and we don't have any overlapping or transition period, we lose all those historical trends. And this happened in 2008 when they changed how disability was asked in the ACS. So for many years, we didn't have any longitudinal data, or not, it's not actually longitudinal data. We didn't have any trend data about disability in rural areas for a very long time. My colleague Lily Greiman was actually one of the first to kind of put that together when we finally had at least 10 years of data. So if you want to do a time comparison with ACS data in rural areas, you actually need 10 years of data to do it. You need one 5-year observation and another 5-year observation. And so if we make these changes without being intentional about how that impacts our ability to track trends in rural places where data collection takes a lot of time, we just need to be cognizant of that, of the loss of historical trends, and ensuring that there's some amount of data continuity there. Another aspect is, and I touched on this already a little bit, but we really need to increase trust about data and data surveillance with rural communities and people with disabilities. I mean, the most recent example is when the Census Bureau proposed changes to the disability measurement, and it took a lot of folks in the disability community and disability researchers and advocates by surprise. And there's been a response to that. The Census Bureau is hosting a convening meeting. I think it's next week, next Monday. Um, but the point I want to make is that too often, data happens to people. It happens to communities rather than with communities. And that goes back to kind of my point about exploitation. A lot of time data is extractive, right? It's pulling something out of the community rather than doing it with them. And this is important because rural is an underrepresented group, and so are people with disabilities. And so then when we try to look at data, when we're working with the intersection of multiply marginalized identities, whether it's gender or sexuality or race, and we bring in other aspects like rural or disability, it's really hard to do those things. And so what I what I think kind of needs to happen is to begin building those trusts in communities, especially in rural areas and tribal communities. But that takes a lot of time and resources, and it doesn't always lead directly to grant deliverables. A lot of time grant timelines are not actually that long. Some of them can be, but some of them are like 5 or 6 years, and there's a good reason for that. But at the same time, if you want long-term outcomes, you kind of need long-term stable funding. And so what I would like to see is research agendas and review panels that see the long-term value in prioritizing that type of community work that is often messy and sometimes improvisation.
Thank you. I appreciated how you both highlighted that not only do we need better data, but also we really need a disability forward lens to ensure we're both collecting and interpreting the data that we have as inclusively as possible. So, thank you for those insights. In the last couple of moments that we have left here, let's turn to just a final quick question for both of you. As we've been noting, we're at a pivotal moment where conversations about disability, data, and equity are taking center stage. From your perspective, if you had to pick just one, what is the most pressing rural disability data priority you would like to see on the national agenda? And we'll just get a quick sentence or two from each of you. Kelsey, why don't you go first?
Yeah. Well, if I had to just pick one, it would be the need for rural-specific metrics that truly capture the unique challenges of living with a disability in a rural community. So it's not just about asking more questions, it's about asking the right questions, questions that reflect the distance people have to travel for care, the transportation barriers, the reliance on informal caregiving, the lack of broadband access. Because it's not just about collecting numbers, it's about understanding the lived experiences of people whose stories often go untold. And when we have the right data, we can create policies that reflect the realities of rural life, ensuring that these communities are no longer invisible in our national health and disability conversations. Because it's time to recognize that every community, no matter how remote, deserves to be seen, deserves to be counted, and deserves to be invested in.
I totally agree, Kelsey. I'm going to build a little bit on that, but I'm going to go back to numbers. I would really like to see disability included as a demographic trait in the decennial census. Part of that is because if we do that on the decennial census, that means we actually get a real count of disability, which is important in rural areas because then we're not just using estimates like those in the ACS, which we are known are prone to error as good as they are. That also includes moving beyond measures of disability as just functional impairment and moving from what I know Bonnie Swinor has called a deficit-based measure of disability to more asset-based measures of disability. I'll leave it right there.
Thank you. I appreciate how you crammed at least several different priorities each. Well done, well done. Great. Now we're going to turn to our audience and see what questions folks have submitted for you both to consider. We've had a lot of great questions come in around disability measurement. And best practices for using the data that we do have available to us. I know you both have pointed out some pretty significant shortcomings, and Kelsey, there's a lot of interest in the survey that you administer as well. But what is the best practice, kind of making do with what we have today? We'll start there. For those who can't go out and collect their own data. Any advice?
I mean, my plug is going to be connect with us at the National Survey on Health and Disability, NSHD. I shared that in some of my answers, and I'm a little slow at typing sometimes, so I appreciate y'all's patience as I get through those. But we do have the luxury of asking really nuanced questions about disability and about rural specific indicators. And we have a data analysis team that we host and engage with researchers across the nation. So would love, to have your involvement in that way, and the more collaborators, the better. And we would just really invite, to explore really rule specific issues, in some of those conversations.
I'll chime in a little bit and focus on kind of the ACS and the disability measures there. There's a lot of research going on about how well those different measures perform across different indicators. Kelsey and her colleagues, Jean and Noel, have been using the NSHD to look at that. I think they're really informative. Um, that said, the ACS 6 questions, as limited as they are, do still provide us that historical perspective, which I always come back to of like, we need to improve, but we also don't want to get rid of those historical trends because as a rural researcher, those are important because it takes time. And as far as best practices go for like working with some of this fuzzy data, especially when you are looking at large margins of error. I mean, a rough estimate is like if the margin of error is larger than the estimate, then maybe don't use it or have a very large asterisk next to it saying this is the best we have, but we also know that it's limited. And so it really comes back to kind of what Kelsey said, which is you still need that on the ground knowledge. You need to build those relationships because the last thing you want to do is go work with a community and have data that does not reflect their reality. So you really need to keep that in mind.
Yeah, I love that advice. That's excellent. And you've kind of already started to answer this next question, but just to plumb the depths here, for folks in the audience who are, policymakers, researchers, practitioners, trying to use and rely on existing disability data sets that we have, what caveats, cautions, advice would you give them, to making sure they're approaching the data as best that they can, as thoughtfully as they can? And again, you've both already shared a couple of examples, but if there's anything else you have to offer for, folks who are doing their best to navigate available data and use it in their decision making.
Do you want to go first, Kelsey?
Well, I just say, it goes back to the conversations of being sure to include people living in rural areas. I mean, again, it's in our nature if we're working in these urban centric research centers or or working with urban centric policymakers that we don't really know all the nuances of what it means to live in a rural community. And so yeah, I would just highlight in those explorations the importance of really collaborating with rural researchers.
Absolutely. Yeah. Sometimes I'm going to try not to use too much academic jargon, but one way of dealing with some of the small sample sizes is to scale up your geography. And so rather than like looking at a small county, you might scale up to a larger area so your sample sizes can kind of increase your scope, right? Like if you're saying, I want to know how much, like what the data says about my community, but if your community is really small and the data isn't good enough to really give you like reliable idea of what's going on, you might increase the size of your, like where you're drawing those boundaries. So rather than working at like the county level, you might scale up to the state level. So maybe you can say something about the state. That's one way of kind of dealing with that tension of small sample sizes. I also think that my colleague Lily Greiman dropped in a really great resource that she's worked on called the Disability Counts. There, that website has like data that's like pretty descriptive, but has often been used for kind of these kinds of things. The data's there, available, ready to go. You don't have to dig around in the data.gov. Oh my God, what a nightmare. It's okay if you know how to do it, but for most people, data.gov is kind of a black hole of information. So just definitely check out disabilitycounts.org. There can be some helpful data products there for you. Yep.
Great. Thank you for those insights and resources. We've had a good question come through that I think you might have some interesting insights too. So, we've talked a lot about measuring disability and thinking about how people with disabilities are captured and described in the data that we collect. But we got a great question about caregivers. Where would you point folks to who are really looking for information about family care or informal caregivers to really understand the landscape there and their communities? And I know our next wonderful panel will be talking through this a bit, but if you have any suggestions for those with us today.
Yeah, that is such a great question. And really, I think hits the nail on the head when we're talking about national data. That type of stuff is like kind of hard to capture because it's relational, right? It's not like a characteristic of a person. Um, you're really capturing an interaction and really those informal networks, which are not often, you know, or standardized data measures don't always capture that kind of stuff because it's, messy and informal. And yeah, I think the next panel will definitely speak to that. But one that comes to my mind is I know that my colleague Raina Sage has done some stuff around personal care and personal assistance services. I know that she's working on looking at some need-based areas, looking at kind of how that looks at a national level to develop some measures of like where that happens more than others. I'm not doing it justice in describing that. But yeah, it's a great question. I'll see if Kelsey has anything to add.
Yeah. Yeah, and I guess I'm a little bit more knowledgeable about the direct support workers and that kind of survey methods. One thing that's been a little novel, I've been working on a project where we've been partnering with folks who do the electronic visit verification. It's like Authenticare, and they have through their apps, direct support caregivers, direct support workers will have to sign into that system to kind of verify that they've been doing their paid services. So that is a data set. I mean, I will say a big limitation of the caregiver workforce is that it's invisible. We don't have a lot of data about that workforce. A lot of states, in the state of Kansas where I work, there's not even a registry of direct support workers in the whole state. So we don't know who these workers are, and we don't really honestly know a lot about them.
Well, you've teed up a great challenge that I know our next panel is really excited to tackle as well. I'd like to just thank you both for joining us today and just sharing your insights from your deep experience in this work. Thank you so much. I'm going to hand things back over now to my colleague Sue Popkin to introduce the next panel. Thanks.
Thank you, Corianne, and thank you. That was a terrific discussion and really does cue us up very well for our next discussion, which is going to be with rural disability and advocates and service providers who talk about trying to do the work on the ground, what information they need, what information they don't have, the compromises they make. I'm really excited to moderate the session with three great panelists to discuss their work along using disability data and to elevate the experiences of disabled people in rural communities. You'll find their full bios online to learn more about their work. And as a reminder, please keep entering your questions for the panelists at any time in the Q&A box. And again, we will reserve the last few minutes to answer a couple of them at the end. In the second panel, we are pleased to welcome three panelists from three very different parts of the country. We're going to start with Tafa Tuapula, the State Director for American Samoa University Center for Excellence in Developmental Disabilities. Mary Willard from Summit Independent Living, and Kiana Jackson from New Disabled South. So really excited to have all three of you with us today. And I'm going to start with sort of a general question. Can you discuss the role that data has played in your rural disability work and any challenges? I'm sure you have challenges you've experienced in accessing or using that data. I'm going to start with Mary.
All right. Thanks, Susan. Again, my name is Mary. My pronouns are she, her, hers. I'm a Caucasian woman in my early 40s with shorter length brown hair. And in the background, I have a Nothing About Us Without Us handprint t-shirt. So I have had many different hats. I think that all of them would be considered being a rural grassroots advocate. I'm also a person with an invisible disability. Yeah, I've used data in a lot of different ways. I will say one of the most emerging ways we used data was during the pandemic. Disability advocates across the country were really interested in especially people in congregate settings in rural areas. And I will just say that data was non-existent. And it still is non-existent. I also have used data, folks who work in rural areas need the disability data on people living in rural areas in order to grow and develop programs. We can't better serve people with disabilities unless we have a good account of how many people with disabilities are out there. And we're just not really doing that yet. And then the other thing I just wanted to add quickly on the challenges on accessing and using the data, because I think somebody earlier had mentioned, that they wanted to be able to, as a grassroots advocate, help get more data that's useful to the field. And I would just say, I think that was one of the challenges that we have as disability advocates, is that the data is not necessarily usable. There's been some really great info put out. I think it was the Rural Institute who did these data disability briefs that broke down data in really understandable ways that then as advocates, we could take out and talk about what was going on in our communities. Not all of us are data and survey research experts. And so I think in order for people to be able to use that data more, we need to break it down more. And then I'll just add that this is just, Andrew was mentioning all the ways we define rural, and that couldn't be more right. I think that something that I've really found is that in rural areas, disability looks different. I grew up super rural, and not always do we think invisible disabilities are disabilities. And that's something that I think we're working on. So I just feel like I loved everything the researchers were saying, and there's a lot more to go. And I will turn it back to you, Susan, because I will talk on and on.
We have time. It's fine. I'm going to give Tafa a chance to talk about, I think something probably most people in the mainland don't think about, the issues about data in the territories. So I think we can all learn a lot.
Good morning. I'm Tafa Tukwula. Tafa Imamau in its entirety. So that really means manifest vision in Samoan. I'm a Pacific Islander living in the Pacific territories. I have dark brown long hair, wearing a long black and brown floral Samoan cultural dress, wearing headphones and a pair of glasses. I refer to as she and her. So in discussing the real data, as a Pacific Islander, that would also require me discussing about the geographic isolated data to provide a vivid image of not just the challenges, but also the limited infrastructure that we have, limited infrastructure of services for the disability and aging to access whatever is available on island. So think about the 3 Pacific territories. We are really located in the largest body of water in the world. And so in thinking about what does our infrastructure or geographic isolated data looks like, American Samoa poverty level is 54%. We have 7 islands. We have 1 hospital. CNMI poverty level is 38%, and they have 3 out of 14 islands people live there, and Guam 20.2% poverty level with just one island. So imagine when in a geographic isolated community, when you don't have services available on island, the data you see in the census doesn't reflect the barriers that we go through on island. At the end of the day, the data that's really reported looks like just a regular number. So our population continues to also drop from the various disasters that occurs in the Pacific region. The Census 2020 reported that a disaster is the fifth reason why Pacific Islanders move away from the Pacific territories. Now that's a problem if we're using formula to drive the appropriation for the territories. So that's another barrier. Um, for a household data in the territories, American Samoa 26.6 are multi-generational homes, CNMI 13%, Guam 15.3%. So why is multi-generational homes important? Because when healthcare or education or services are not provided on island, the entire family moves. The entire family moves. Imagine that. And when they move to the mainland. The census reported that family-related issues is the fourth reason why Pacific Islanders move away from the territories. And so this becomes a problem when once we leave, we don't return back home. And so for a Pacific Islander, we're really tied to the land. Our culture is not the only reason why it shapes our identity. It also ties to the cultural land there. So this is the driving force behind everything. So I also want to end with kind of talking about the tools and indices that utilize data that excludes the Pacific territories, such as the vulnerability indices. And when we talk about that, how does this index that excludes the Pacific territory addresses racial equity amongst the disability and aging community in the Pacific? So thank you.
Thank you. That was really interesting. Give us a real perspective on the challenges. Kiana, you want to talk about what New Disabled South is doing and what the challenges are there?
Yes, 100%. Hi, everyone. My name is Kiana Jackson. I am a Black 26-year-old feminine presenting person. My pronouns are she, her. I have locks in my hair. They are dark at the root and blonde at the tip. I am wearing a pink corally shirt, and I have on glasses as well. I think I myself grew up in rural communities. I am from Albany, Georgia. I grew up in a food desert. I grew up in a community that has a lot of healthcare resources that a lot of people also don't have access to. I think a lot of times we talk about healthcare resources and the quantity of them. I think we have to talk about people's ability to access those as well. And those are compounding things that contribute to disability. One of the main things that I have encountered with doing disability data work is, as an example, we do a lot of work around home and community-based service waivers. And for most people, if you don't know, home and community-based service waivers are essentially funds that states can allocate to people. And this is a very generalized part of it, but funds that states can waivers to get people in home services to keep people in community. And a lot of the work that we do around that, we run into a lot of challenges with reporting on that. And this is largely due to inconsistencies. There is no standard in reporting on home and community-based service waivers. So you'll have some states who you'll do a FOIA request, which is a Freedom of Information Act request, and they'll give you everything that they have. And then you have some states who don't collect racial data, some states that do but won't give it to you. A lot of these different varying states, they have Georgia had two main waivers. our first report that we produced on this was in Georgia. And we were seeking to identify or see if there were any racial disparities, and we found several. And we know that racial disparities exist in all forms of public health. And we wanted to see how this showed up in terms of people receiving services as well. And so in our pursuit of doing this research in other states, we are seeing a dramatic difference in, one, the information that people are willing to share, but also the information that they collect. You have some states that have 10, 15 different wait lists. And wait lists are, a lot of times people get on these, they apply to get on these waiver wait lists. And we have talked to people that have been on these lists for 10, 15, 20 years, waiting to receive services, which is kind of the catalyst for us even doing this research and to push state legislators to allocate more money to it. But then another thing that we saw, and someone raised this point about it, is we have also encountered people who get off these wait lists, and they get the waiver, but then they don't have anyone to provide a service because there are a lack or a shortage of direct service providers. And so then that kind of led us down, why is there a lack of direct service providers? So what we found ourselves doing is going down these rabbit holes and creating data points that just don't exist. And I think that is one of the greatest challenges in doing this work, in realizing this data does not exist. And how do you create these data points when you are trying to maneuver state aggregated data while also trying to acknowledge the complexities that come with intersectional identities? I'm a Black disabled woman, born in the rural South. That is, I sit at several intersections. I am a data point. How do we identify these nuances? It's the struggle, and something that we've also ran up against, because one of the criticisms, is being honest, that we kind of got was they were like, oh, y'all are talking about race and we don't look at race. But the thing about every data point in healthcare is that race always plays a critical factor. It is one of the key intersections when it comes to access, when it comes to outcomes, when it comes to availability of resources. And we kind of, doing any disability work, we find ourselves, like I said, creating these data points. And that's a key challenge in making data that just doesn't exist. And also realizing that data doesn't always tell the whole story. So I'm a data scientist by trade. I love it. I love an Excel spreadsheet, but also understanding that these are data points, but these are also people. And figuring out, how do we tell these stories in a holistic way that give credence to the data, but also rehumanizes the people that we are investigating or researching as well.
Well, you've set us up perfectly for our next discussion. So I think all the issues around people not being able to see themselves in the data, not having the data you need. Really, what do you do? Can you share an example of what this has looked like for the communities you've worked with? And what are the strategies that you've used to make rural residents with disabilities visible in data? I heard you talking, Kiana, about having to create the data points you need. But I know when we met to prepare, all of you also talked about the importance of story and figuring out other ways to tell the story. So I'm going to start with Tafa this time.
So I would like to say that there's more from a Pacific Island experience. We don't just include, it would not be just the disability, but the entire family that evolves around the life of the individual with disability. And that would be the unpaid caregivers, because the necessary support that is needed throughout their life for those in need of long-term care and support. I think a lot of the unpaid caregiver data would contribute greatly. I think about how the unpaid caregivers also contribute to economic security in our own communities. I also think about the experience that my mom went through caring for my father, and then her being an aging caregiver. And when she would take my father to the hospital, it was just for his regular checkup. But what the doctor said to her stood out for me, and that was having a disability for more than 3 years, he could not. He asked my mother one important question: what does she do to take care of my dad for him not to have one single bed sore? One single bed sore. And yet, that's the highest reason why older adults are hospitalized in American Samoa. And when it was time for her when my father passed on and it was time for her to file for Social Security, she did not have enough Social Security credits. All her years of caring for my father, keeping him out from the hospital, which we try very hard to not institutionalize, and doing this as a family member, we're just only repeating the cycle and increasing the poverty rate in the territories when they're not counted. So I would like to see how can we elevate other unpaid caregivers who contribute to the economic security, but are not really recognized for their economic support within their own community. Thank you.
Thank you. Kiana, do you talk a little bit about what do you do to try to make rural residents visible, and how are you creating these data points?
Yeah, 100%. I think that it is going back to, I think several ways. So one, I think it's changing the way that we view how we view disability, especially when it comes to data and in research. A lot of times the data that you see around disability or the research that you see around disability is from this really medical model, this curing model. How do we eliminate these people from society? Just to be honest. And I think that we have to change the way we view it and focus on lived experiences of disabled people, and not a bunch of temporarily able-bodied people, figuring out how do we get rid of like huge chunks of the population. It helps to know that 1 in 4 adults in America are disabled. Once the numbers start rolling out, when we see that trend change post-COVID with people who are suffering from long COVID, once we see those trends, we can expect for that number to rise. And so it's going to be really important for us to start focusing on how do we address the needs of disabled people. And that needs to be what is driving our research and our data. Something that we did at New Disabled South, going back to our HCBS research, is we focused on the services and the lack of services that people have in Georgia. We identified Georgia has a $10 billion budget surplus. Looking at that budget surplus, we in our report broke down and said, hey, Georgia could actually fund every single one of these waivers for less than 1% of this budget surplus. For less than 2% of this budget surplus, maybe less than 3% of this budget surplus, Georgia could actually give a raise to all direct service providers and move them from being paid $10 an hour to $18 an hour. Not only would this give people in the state something that is a legal mandate that I think like we'll get into a little bit later, I'm sure, but like Olmstead is a thing and people have a right to be in community, and the states are obligated to make sure that they are taking initiatives to do that. And so it's our job as data people, as researchers, to identify when these gaps are happening and when states aren't in compliance with making sure that disabled people are able to live full and thriving lives. Another thing is, I think our data and our research has to move from just being so focused on aggregated and numeric data and more focused on the importance and the robustness that is qualitative data. Something that we have really focused on and incorporated is sitting down and having these conversations and allowing disabled people to tell their story and not it being filtered through the mouths of people who aren't living their experience. Lived experience is a data point. Qualitative data is important. Those stories are contributive to research. And I think that using those qualitative initiatives or efforts in places where we don't have the data, right? Our job is to go and create this. And so often we're looking for a table or a chart when really what we need to be doing is sitting down and talking to people and getting people's lived experience, navigating these systems, navigating the nuances of accessing services and accessing care, and allowing that to be the sort of drive for our conversations around all things related to disability.
Thank you. That was terrific. And Mary, I think you've talked also about the importance of asking people their stories and using those to tell the story of needs of disabled people in rural communities.
Yeah, this is Mary. I just really appreciate what both of my fellow panelists said. Tafa, you really struck a chord with me. You were mentioning about how it's really about family and looking at the whole family. And I think that to me is so rural. So I've spent probably 20 years in the rural independent living movement. And in the rural areas, we're still talking about disability different. Like some of my urban counterparts had this whole say the word hashtag disabled and really taking that pride in being, saying that I'm disabled because a lot of times it's the social environment disabling me. A lot of the really rural areas, the folks that I work with, we're still saying a person with a disability because it doesn't, I'm just going to say, well, my friend Jim summed it up. He was a disability advocate in a rural area who told me there was nowhere that he couldn't go as long as 5 of his friends wanted to go. And so just in rural areas, I feel like we are so creative in just figuring it out. And I think Tafa also mentioned that too, just like it's just how it is. And so a lot of people don't necessarily see themselves as having a disability or being disabled. But I want to mention a couple of things. One, that's why it's so important in order to let people tell their story. I think Kiana mentioned that too, because you're going to get so much more information just sitting down with somebody and letting them share their story. And then you can start picking up on some of the language that might identify barriers they're experiencing, or maybe, hey, they do have a disability and they just don't know it yet. I think, we've had folks in rural areas when they were going out trying to get surveys filled out, they actually would just go to the community, sit down with people and fill their survey out with them. I think, expecting somebody to take time out of their day to fill out a survey, maybe it's not in their first language, maybe they're not feeling like a strong reader, or it's not something that makes sense to them. So just going out and actually being in that community and having a presence, I think is going to really help get better data in those rural areas. And then the other thing I just want to say, there was a couple of comments again from grassroots advocates asking how they can help make data better. And in the independent living movement, I literally just started knocking on researchers' doors. I'm grateful that there are a lot of really kind researchers who saw the importance of having disability voices represented in the work they were doing. But I invited myself to an AUCD meeting, which is the Association of University Centers for Disability. I just started handing out my card and I was like, do you want disability voices in your project from start to finish? And I would just say, just start doing that. I think that the more that we show up and we offer opportunities for researchers to continue to learn and get better data, that's how we're gonna, I think, break the cycle.
Really like that idea. Just engaging directly, getting the researchers to pay attention. For our last question before turning to the audience, and we're getting a lot of terrific questions again, so keep them coming. I'm going to ask the same question we asked our first panel. From your perspective, if you had to pick just one, what's the most important pressing rural disability data priority you'd like to see on the national agenda? And I'm going to start with Kiana this time.
So to me, the most important thing would be, and just for its broadening, and the widespread ramifications of it, is the recent Chevron decision. And what that impact is going to be on Olmsted. So the Chevron decision was a recent decision passed down by the Supreme Court that kind of undid federal agencies' right to sort of regulate enforcement and of these national laws and these decisions, Olmsted being one of them. And Olmsted was, I mentioned it earlier, gives disabled people the right to live in community. And I think that to me is going to be a significant data point, not just from a research standpoint, but from a grassroots organizing livelihood standpoint. I think that there are so many harsh realities that are not far from existing with a ruling like Chevron. And it does cause me great concern to think about what that impact is going to look like on things like home and community-based service waivers and states feeling the need to make sure disabled people can live in community. And to fund those waivers. We don't know what like I said, we don't know what the widespread ramifications of that decision are going to be. But I know that there are going to be some pretty harsh ones, particularly for us that live in the South. And I think that is going to really.
Can you talk a little bit about what you're afraid might happen?
Yeah, 100%. I am concerned. We are not as far away from forced institutionalization of disabled people as we might think. And if states feel that they no longer have to make sure that, or they have no responsibility to keep disabled people in community and make sure that disabled people have the resources to access a fulfilling life, then, especially as someone in the South, social needs are not always are rarely a priority. And the thought that we no longer have federal agencies that can regulate that can mandate states meet some threshold, that has a review process to make sure that this is a top priority. The enforcement of these acts in federal and federal legislative decisions, to remove that power, to remove the review power of a regulatory body that sets a standard or attempts to set a standard. It is extremely concerning because and it could just be being in the South, but I know the recent Supreme Court decisions have not been in the best favor of marginalized or multi-marginalized communities. And we see the effects of that every day on the news. And so I think to have a decision like this that removes regulatory power in favor of, hey, well, let the states kind of do whatever they want to do, essentially, when it comes to enforcement or abiding by these legislative federal laws. It's extremely concerning, especially when you are looking at things that a decision that literally keeps disabled people out of institutions and mandates and states to utilize resources to make sure disabled people can live in community, to have a decision that says the federal government no longer has the same power to regulate this process as they once did. Given how already dire our home and community-based service waiver waitlists are, I mean, in some states it's up to 300,000 people on these waitlists. The only thing keeping them would be, in my opinion, these type of federal acts. And now that we don't have any type of regulatory power by the federal government, I just shudder at the thought of what could happen and what will happen when we don't have that type of oversight.
Thank you. And Tafa, do you want to talk about what your most pressing rural disability data is for the territories?
I think it would be a more equitable funding for the territories. As I shared earlier, that we are located in the largest body in the world. So imagine when we have to access healthcare, access education, or even just be a part of a conference in person. And we always know that if the in-person conference is available to everyone, imagine the costs we have to budget just to be included. And with just 1 or 2 flights a week, but we're included. But the downfall is that majority of our funding goes to addressing the inequities to be a part of the larger group. So there has to be a more equitable way of collecting data, interpreting data, so funding can be made and appropriated for the territories in a manner that everyone can be a part of, and we're not finding ways to be considered to fill in the gaps. We all know that we spend more money addressing the inequities than we do, then the remaining amount of funding left is really going towards the activity. And so that is what we go through in many ways. And, you know, we have this saying as Pacific Islanders, it's the ocean that divides us from being a part of everyone. But it's also the ocean that connects us. But what does it take for us to be connected? That's the gap. So I'll leave it with that. Thank you.
Thank you. And Mary, I'm going to let you wrap up this question.
Oh, thank you. It's hard to follow both of you.
I know.
You know, and I just have to say something, Kiana, you said, it really just sat in my gut for a minute. And it was that we're not that far from forced institutionalization. And I just, before I say what I want data in, I would just challenge everybody in the audience, if you're not a part of the disability rights community, to go out and look up ADAPT and the Free Our People movement, and learn a little bit about why institutions, why we are fighting so hard against them. I think, I don't know that everybody knows the story, and that, you know, when people are institutionalized in nursing homes or incarcerated, you know, you are more likely to die. It's more expensive to live in these places. So anyways, check out ADAPT and look at our history of a disability movement and why we're fighting against institutionalization. And I just wanted to then add to that, it really brought to my mind, I'm going to change my answer from our prep calls. And I would love to see better data on rural people with disabilities during emergencies. Because when you said we're not that far from forced institutionalization, it really stuck with me, because we were forcing people into institutionalization, and we do it all the time following emergencies. We saw it during the pandemic. We see it following, you know, natural disasters, that people with disabilities are forced into institutionalizations. One I think for one reason, because we don't have good enough data on them. We don't know exactly what's needed out in the community during these disasters in order to prevent that. So I'd like to see more data in that area.
Thanks to all of you. And we have about 10 minutes for an open discussion. If folks want to keep adding questions. I guess I'm going to pick up on what you just said about emergencies, because I see we are forecast for one of our first big hurricanes of the season today to hit Florida. And we know what happens when there's an emergency and people have to be relocated, and especially in a state like Florida where there's a large number of seniors. And I guess I'd like to hear from Kiana and Tafa more. You also mentioned emergencies, what that means and why it's important to have information.
Yeah, so I am in Florida, right in the eye of the hurricane. And
Oh, I'm sorry to hear that.
and that's actually most of my family is in Georgia as well, which is also in the path of the hurricane. And so I think these questions around like what do we do with disabled people when there are emergencies? I think I just I think it comes down to community care. I feel like we put so much on community when we have these sort of institutional things that are supposed to work, but or governmental things that are supposed to work. But I think it really comes down to community care. As a disabled person, as a person who comes from a family of several people who are disabled, when we have these emergencies, I think it goes to sort of like that just humanity, that humane part of saying who needs me most in this moment and what can I do best to keep this person, one, surrounded by people who love them, surrounded by people who care. I know some work that I did back in 2020 during the height of the COVID pandemic. So Albany was also a COVID hotspot. We did a lot of work around, particularly in congregate settings, a lot of work around providing care, providing PPEs, providing food. We did a lot of grocery shopping for people. We did a lot of resourcing for people. We help people with pay bills. We help people pay their utility bills. We help people get their homes fixed up. We work with community partners and we got grants and funding to build. And the broader part is like grants and funding to help build ramps so that people can get into their homes, to help modify people's homes so that disabled people weren't forced to leave their environment or their home. And so I think it kind of goes, anytime we see where the government falls, community tends to pick up. And I think it just goes back to that. It goes back to that community care aspect and how do we build community care and this sort of interdependence in our nature as just human beings. How do we create this sense of empathy and shared concern? I think that's one of the main ways we do that.
Todd, you talked about people having to move because of emergencies.
Yeah, so what our Medicaid actually covers transportation, and that would also include air transportation. So if services are not available on island, when COVID happened, our borders were shut down for a whole year. And so that meant if they couldn't get the Medicare medical attention on island, they would literally charter a flight to take everyone who needed urgent medical attention to fly them out to Honolulu. So that also meant that as they got access to healthcare, they knew they did not have a return date. It was not clear when we would open the borders. So there were a lot of resistance with the closure of the borders, putting pressure on the government to open the borders. But at the end of the day, it protected our community for 2 years because we knew our hospital could not handle the demand if COVID was to break out in our territory. But I also want to highlight that American Samoa was the only place in the world that was free from the Spanish flu. So when the Spanish flu broke out around the world, we also closed the border. So you can say we were trying to repeat history and close the border again because there was so much unknown. And so we also learned from what the world was doing in response to COVID. And so this is what impacted our 2020 census because people were locked out of the borders when the census was occurring on island.
Thank you. I think we got one question from the audience about a barrier that we always meet when discussing data collection in their state, which must be mostly rural. Is the problem, this has to be a problem for all of you too, is the problem with small sample sizes and identifiable health information being a privacy problem. And rather than accepting this as an excuse not to collect the data, how would you enable and empower public health data owners to help us characterize disability status in rural communities? You've had thoughts on that? How do you deal with the fact that it's protecting privacy and getting the broader information that you need?
I think that there are ways to collect this data. I think governments are very creative when they want to be. And I think that that's what we have to hold people to as well. It goes to, I know one of the questions that I saw in the chat talked about like, how do we organize communities to have that care? I think, how do we organize these systems that are in place that are collecting this data to have that same care is a similar question. Care creates creativity. It breeds creativity. And you'll get these government documents that have all this information and they have redacted everything besides exactly what you asked for. The data is I challenge because it's not, well, a lot of times you say the data point doesn't exist. I don't always think that the data doesn't exist. I think there's a lack of willingness to share data that affects public health in a bad way. And I think that if our public healthcare system would not be so obsessed with their image and just cared about transparency, we would have the data that we need. And I think what we have to start doing is pushing healthcare to be accountable to the public. And two, if you don't trust us with these numbers, then you have a responsibility to give us these numbers in whatever way that you can. And that push doesn't always happen. It's like, oh, well, we can't give you that information. And then we as community groups or advocacy groups take on the burden to go and say, okay, well, we'll create this data. But we're not the ones getting $6 million, $7 million, $10 million grants from the government to collect this information either. The people, these institutions, these medical institutions, these research institutes, they are the ones that are doing that. A lot of that is coming from public funds as well. And so just like we hold our elected officials accountable, we have to start holding public health accountable for the information that they are collecting, and not just accepting, oh, well, I can't give that to you because of X, Y, and Z. You can give me what you can, but right now you're choosing to give me nothing. And I think that we can no longer accept nothing. We have to start pushing for transparency in public health, particularly when it comes to disabled people, and particularly as disabled people are becoming a more broad, more people are becoming disabled every year. Like I say, post-COVID, more and more people are disabled because long COVID was a mass disabling event. Disabled people need transparency in this moment. We need medical transparency. We need public health transparency. And we cannot, as the person said, continue to accept, oh, we just can't give you that information. If you have it, there has to be some way where you can make it available. If you don't trust the public with it, the raw data, then you need to be regularly releasing things on the information you are getting.
Thank you. Mary or Tafa, anything? Okay, go ahead. Go ahead.
Sorry.
We have about a minute left.
Perfect. This is Mary. I just wanted to, I just went back and read the question again. Sorry, I'm a visual. But I think one thing that really sticks out to me is that they ask, what can we talk to CDC and public health data gatekeepers to empower them to characterize disability status? I think they're looking at disability and health conditions as a negative thing. And I think this just goes back to, again, the incredible work that we still have to do in the disability community to help people see that it's not bad, it's not negative. Disability is a natural part of life. And I think that's the first thing, is to really continue to change that script. And then, I don't know, I think the other thing is the small sample sizes. I think that people understand, if you're doing it right, that they can select into the data, right? Like, you can't force somebody to fill out your data. I think as long as you're, explaining to people that their information might be out there, and their information also might help change their community for the better. And if they still fill it out, I don't see what the problem is. I feel like that's just an excuse for the CDC to not gather data, personally.
Thank you. Tafa, any final words before I close us out?
No, I just agree with everyone, what Kiana just said, but I really think those who are in the community are at an advantage to collect the data from people who they're used to seeing on the ground. Again, the territories are constantly exploited from outsiders trying to collect data, so we have this trust issue. So I really think this is an opportunity for the boots on the ground within our community, who are familiar faces, to take the lead in collecting data. And we have a better way of analyzing it. Thank you.
Well, I want to thank each one of you for being with us today. This was just a terrific, rich conversation, and we obviously could have kept going this conversation on rural disability. And I think it's highlighted the importance of rural data and rural disability in the bigger conversation about measuring disability. The recording for this conversation will be available on Urban's website in a day or so. And I think you've seen, it's already been Haley put in the chat that we have a survey we appreciate people filling out afterwards to let us know how we did. Thank you so much. This was just a really terrific conversation. I know I learned a lot. So we really appreciate you being here with us today.